Okay, so it's my pleasure now to introduce Brian Diaz. Dr. Diaz is originally from Saskatchewan Medical School and then went and did further training in both at Western and in Hamilton at MAC. He went on then to do a fellowship in echocardiography in Toronto and then saw the light and left the center of the universe and went to a nicer place, I'm sure. And is joined the Department of Division of Cardiology as an Associate Professor of Medicine at Western. And his clinical interests include the topic of today, which is of great interest to us, and is carcinoid heart disease. So Brian, welcome.
Thank you very much for your kind words. I'm going to sound very disingenuous because before this gentleman made this comment about the meeting, I was actually going to thank Maureen and compliment her on a fantastic job. Really, this is something that just absolutely amazes me, how Maureen can organize such a first-class meeting and do it so well and have everything run. Congratulations, Maureen. So, I'm the token cardiologist, a non-oncologist, but I have trained in internal medicine, and I've been asked to basically try to shed some insight as to why a cardiologist should be invited to a meeting where all the oncologists are here and no other cardiologists. Well, first of all, going back in the literature and in the 90s, it was believed that carcinoid heart disease was very, very common, prevalence of approximately 60 to 70%. And when I got involved in this field in London, Ontario, I thought I was going to be very, very busy. And during the course of this talk, you'll find out that things have changed in the field of carcinoid heart disease. Well, what causes carcinoid heart disease, and how do you make the diagnosis? Well, I'm a cardiologist, and cardiologists think in simple terms. So essentially, in carcinoid, you have a tumor. Tumor secretes substances that cause problems. And the problems, if they're just localized to the gut, get deactivated by the liver. If, however, you have metastases to the liver metastases now secrete those hormones, and they get dumped into the hepatic vein. The hepatic vein eventually drains into the right heart. Those substances then will affect the structures in the right heart. Now, the heart is a very simple organ, two sides, a right side and a left side. The right side takes blood that's being deoxygenated, has been used by the body, and dumps it to its next door neighbor, the lungs. The blood is then cleansed in the lungs, is then returned to the left side of the heart. And the left side of the heart has to pump it everywhere. For a cardiologist, the really important part of the heart is the left side of the heart, because that does the major work of the heart, because it pumps blood everywhere in the body. That's where heart attacks occur. That's where usually the valves are affected in the heart. And the reason I bring that point up is that in adult cardiology, we forget about the right side of the heart. And it is the right side of the heart that is affected in carcinoid disease. Now, what happens is that we believe these substances actually go to the right side of the heart, and they affect the tricuspid valve, which is between the right atrium and right ventricle, and the pulmonary valve, which is between the right ventricle and the pulmonary artery. And what happens is that there's this deposition of this pearly white substance onto the valve structures. And eventually, with time, what happens is that this deposition of this plaque-like substance prevents the valves from working. You get a combination mainly of tricuspid regurgitation and pulmonary stenosis. But the reality is you get a combination of what we call tricuspid stenosis, where the valve can't open very well, tricuspid regurgitation, where the valve can't close very well, pulmonary stenosis, valve doesn't open too well, pulmonary regurgitation, where the valve leaks quite a bit. Now, that's what happens to the right side of the heart. What about the left side of the heart? Well, you can get involvement in the left side of the heart. And being a cardiologist and thinking simply, 3 reasons why. Reason number 1, you're bypassing the lungs. The lungs filter out these substances and deactivate it. At least that's what our thought is. So if you can somehow bypass the lungs, you can get this tumor substance into the left side of the heart. So number 1, if you've got tumor in the lungs, so bronchial carcinoid, you're going to affect the left side of the heart. Number 2, if you've got a shunt in the heart, so something called a patent foramen ovale, where there's a little communication between the atria, you're going to shunt blood from the right side of the heart to the left side of the heart. So hence, you're going to get substances into the left side of the heart. And number 3, if you have overwhelming tumor secretion that the lungs can't sponge out that substance, you're going to end up with tumor substance into the left side of the heart. So, what causes these problems? Well, we think the problem is serotonin. And the reason we think the problem is serotonin is for a number of reasons. Number 1, animal models. And animal models where patients are given high doses or exposed to high doses of serotonin, they develop these problems. Number 2, I don't know if you remember, but there were a lot of diet drugs on the market in the 90s. Well, these drugs had things like phentermine, fenfluramine, and really their breakdown product was something called serotonin. And these people who were exposed to these diet drugs developed similar lesions, but on the left side of the heart. Again, cardiologists being simple people, we said, well, you know what? If it looks like it's going to be serotonin, it probably is serotonin. And lastly, we now have found that some of the anti-Parkinsonian drugs actually also are causing problems with valves in a very similar manner to that which occurs in carcinoid. So, how do we make a diagnosis? I'd like to say it's very easy, but it isn't. A lot of the patients that get sent to me, unfortunately, nobody has made the diagnosis not only of carcinoid, but they've missed the diagnosis that the valves are affected. And on the slide, I've already gone through quite a few of the points. The valves, you would think, would be easy to be able to pick out that they're abnormal. In reality, the only test that is any good is an echocardiogram. An echocardiogram is an ultrasound of the heart. We get a real good look not only of the valve structure, but of the muscle structure of the right ventricle and the left ventricle, and also the pressures in the lungs. ECG, which is the electrical tracing of the heart, is almost useless. A chest X-ray only shows some abnormalities in severe cases. Well, what happens if the valves don't function properly? Well, what happens is you basically get a buildup of volume in the right side of the heart. The heart starts to dilate. Well, when the heart starts to dilate, it's okay for a short period of time, but eventually the heart fails and you get congestive heart failure. Now, when people think of congestive heart failure, especially my fellow cardiologists, they think of heart failure that occurs on the left side of the heart. Now, if blood is backing up from the left side of the heart, it backs up and goes into the lungs, and people get short of breath. And that's the cardinal symptom of congestive heart failure in the left ventricle. However, in carcinoid, the problem's in the right side of the heart. And so blood backs up from the right side of the heart and backs up in the body. So the number 1 symptom is fatigue. And it's just a very, very common symptom, so it's very hard to make a diagnosis. When heart failure is severe, the blood, the fluid, backs up everywhere in the body. So you get fluid buildup in the legs, edema. You get fluid buildup in the stomach and the abdomen. That's called ascites. In the actual very end stage, the patient is actually completely debilitated. They can't really absorb any food from the gut because there's so much fluid in the gut, and essentially the patient starts to lose weight, and that's the terminal stage for right heart failure. Now, so yeah, that's all great, but what can we do for our patients? Well, cardiology has become very good at mega trials, where we actually take tens of thousands of patients and randomize to different treatments. We've actually become the superstars in the field of medicine in this range. And all our treatments are based and geared at the left ventricle. And we have fantastic tools to help the left ventricle. Drugs called ACE inhibitors, angiotensin receptor blockers, aldactone, beta blockers. We do, now when somebody comes in a heart attack in our institution, we basically, no matter what time of day it is, or day or night it is, we basically rush into the hospital, take the patient to our cardiac cath suite, and open up the artery that's causing the heart attack. And so we've become very good at dealing with the left side of the heart. But the right side of the heart is anatomically much different, and as well, it looks and behaves in a much different manner. And to be quite honest, we have very, very little data on how to treat right heart failure. We're almost back to where we were maybe 50 years ago in our advent of treating heart failure. Back in the 1950s, we would treat heart failure with diuretics, which basically are water pills, and something called digoxin. And in 2010, that's what we still do for right heart failure. We really don't have any other drugs that have been shown to be effective. The medications which are good for the left side of the heart, the ACE inhibitors, angiotensin receptor blockers, beta blockers, have never been shown to be effective in the right side of the heart. I take that back. We've never had a chance to see if they're actually effective in the right side of the heart because we just don't have the patient population to study it in. What we do know is that surgery is effective, and surgery entails in these patients valve replacement. However, in the 70s and 80s, when we would look back at the data, we would find that there were two major problems that would be causing deaths in the perioperative period. One was that the right ventricle failed, and the second, it was bleeding. So, what about 2010? In the next couple minutes, I want to just go over what are the key landmark studies in carcinoid heart disease and where we're going. So, some of you might have carcinoid heart disease. I know at least one patient here who does because he's my patient. And he's already asked me these questions. Questions include, what's my prognosis and what can we do? Well, first of all, we know that patients who develop carcinoid heart disease compared to those who do not develop carcinoid heart disease do much poorer. And most of them die of heart disease. Second is that patients who have carcinoid heart disease have much higher levels of serotonin or 5-HIAA than their counterparts who do not have carcinoid heart disease. So the first landmark paper came out in 2003, and this was out of the Mayo Clinic. And people can criticize this paper for all that it's worth, but it actually is quite an elegant paper. They have a really nice database, and they follow their patients very closely. So this was a study of just over 100 patients, and they had already realized that, hey, patients who basically had a higher level of serotonin were more likely to get carcinoid heart disease. So let's do something about it. So the somatostatin analogs were on the market, so they were very aggressive in getting these people in on these drugs, and as well, they started doing hepatic embolization. Goal was very simple. Let's try to reduce the levels of the serotonin, and let's see if that will slow down the progression of the carcinoid heart disease. Now, this isn't a randomized trial, but it's the closest we have to a randomized trial. 71 patients received treatment. The other 42 did not. And what we really found was that lowering the levels of the serotonin or 5-HIAA had absolutely no help or did not slow down the progression of carcinoid heart disease. So once you have established carcinoid heart disease with significant valve lesions, trying to reduce your serotonin levels specifically to try to reverse or retard the progression of the valve lesions is not effective. Now, the Mayo Clinic group in 2005 did a retrospective review over 3 decades, 200 patients, and basically looked at the 80s, the late 80s to 90s, and then the late 90s, and basically looked back and said, how are these patients doing? And what they decided to do in their retrospective analysis, so they were actually dredging data, was look at all-cause mortality. They did a very, very elegant study. And what they found is in patients who had carcinoid heart disease, the median survival improved significantly, 1.5, 3.2, and 4.4 years. Now, one of the questions you might say is, well, how come they went 81 to 89, 89 to 95, and 95 to 2000? Well, this is how the statisticians did it to basically get a picture that would make actually some sense. It wasn't something specific to treatment that had changed over those years. So, survival improved. Well, why did survival improve? Well, when they went back and they looked on a multivariate analysis why survival improved, it was cardiac surgery. So patients who had cardiac surgery did better. So that was the only thing that they found that actually showed why patients had improved survival, was that these patients were getting intervened on surgically. They also went back and they tried to figure out, well, who did poorly? And they found that really the major reason was the right ventricle was failing. It was enlarged and hypokinetic, meaning it didn't work too well, and that they were in advanced heart failure. Criteria for surgery was basically people who had heart failure symptoms. Now, 2008, there's a new group or new center on the market in cardiology that's doing really wonderful work in carcinoid heart disease. It's in the London, UK, and they came up with 2 studies in 2008. First was to try to figure out, well, what's the prevalence of carcinoid heart disease? I don't think it's 70% myself, and I think most cardiologists and oncologists don't feel it's 70 to 80%. So what they did is they took all comers. So they took 150 patients who were referred to their center with carcinoid heart disease. And remember, this is a large tertiary care referral center. So it could be somebody who is in the early stages of carcinoid heart disease, somebody who's in the late stages of carcinoid heart disease. And they all had a transthoracic echo. And what they found was that only 20% of patients actually had cardiac disease. Not the 60 or 70% we thought, but only 20%. Also, most of these patients had minimum symptoms. What they also did, looking at their database, was that when they checked the blood work and the urine, these patients, not surprisingly, had much higher levels of serotonin than those who had no evidence of any heart disease on echocardiogram. The other important part of this that I'd like to kind of tell you is that people think that putting a stethoscope on the heart, man, you're going to be able to figure out if this person has valve lesions or not. And the answer to it is no. 40% of the people who had valve lesions, a cardiologist couldn't detect the murmur. And so the take-home message from this paper is that echocardiograms are important, and echocardiograms should be part of our arsenal for the oncologist to look for carcinoid heart disease. Now, this next slide, I've gone over a couple of the points already, but one of the questions is why the decrease in prevalence? Well, clearly I'm not the expert. They're the real-world experts are in the audience, and they've spoken to you already. Maybe it's the anti-tumor therapy. I really don't know. Maybe these people are being picked up earlier. Again, I'm not too sure. But the 2 key points that I want to bring up from a cardiac point of view is, number one, a lot of these patients would have slipped through the cracks and nobody would have detected that they had cardiac disease unless they had an echocardiogram. And from a cardiologist, the other key point here is we need to see these patients before they start to get symptoms. When symptoms occur, it's usually significant damage has happened to the heart. So those are the two key points of that study I'd like to bring up. About the time of our meeting in Toronto, another study came out from that group, and they went one step further. They measured something called BNP. Now, BNP is used throughout the world, especially in the States. It's brain natriuretic peptide, and it's a neurohormone that's released by the heart when there's heart failure. So essentially what happens is patients in heart failure, the walls of the heart are stretched, this peptide is released. Well, what they did is they actually measured BNP in these patients, and a lot of them were the same patients that were in their prior study. And what they found was BNP was a very good screening test. If you had BNP, you had valve disease. And the other thing was the higher the BNP, the worse the heart failure symptoms. And it actually correlated very well. Now, in Canada, we aren't allowed to order BNPs because we can't afford it, but in the States, BNPs, at least to my understanding, are you can actually use, and it should be a part of a screening test for somebody who has carcinoid disease. So, I apologize for going through this information in a fairly quick manner, but this is my last slide, so bear with me. So the good news is the prevalence of carcinoid heart disease has dropped, and dropped more significantly than what was thought of 15 years ago. Why this is the case, nobody actually knows for sure. What we do know is that echocardiogram is very, very important for picking up cardiac disease, but more importantly, for following these patients. Brain natriuretic peptide is a good screening test and probably should be used in the States and in Europe. And that cardiac surgery, which I did not go into a lot on this talk, is actually a very good therapy for patients who have significant carcinoid-induced valve surgery. These patients need to be followed by a cardiologist who has expertise in carcinoid valve disease, and surgery needs to be done before the right ventricle fails. Thank you very much for your time. Okay. So Maureen, who's the boss here, has told me that there's time for 2 questions, if that.
But you have to leave.
Yeah, because I have to leave. Go ahead, sir.
Quick question here. Your phrase was, in time, the pearly white substance tricuspis develops, I guess, on the right side of the heart. My question is, when you have mid-gut carcinoid, how soon should you be checked for an echocardiogram? Every single month, every 60 days? And then how soon should you be checked for this, was it BNP?
Okay.
Also every 30 days?
So the question, 2 questions is, how often should you be checked if you have carcinoid disease for how often should you be checked and when should you be checked for cardiac disease by echocardiography? And the second is the BNP. So echocardiograms are very good to look for any structural problems with the heart. They should be done at baseline. If there is a very low level of 5-HIAA, basically the light, and there's no evidence on the echocardiogram that you have any cardiac disease, the likelihood is you are not going to be getting any involvement with the heart anytime soon. Probably should be getting it done at least once a year. I would prefer every 6 months. If there is any evidence that you actually do have carcinoid disease, that changes everything. Carcinoid disease in the heart. Then you should be getting checked with a cardiologist, and that should probably be every 3 to 6 months until we get a good idea from a cardiac point of view where your cardiac disease is. BNP is just a screening tool. So basically, if it comes back negative or a very low level, you have nothing else to worry about. If it's high, that means you basically need to say, hey, something's going on with the heart. We need to do some further investigations. Did that? Yep. Okay. So I'll ask. Okay, Dr. Wallen.
Just two brief questions. One is, do you see a role for routine use of cardiac MRI or transesophageal echo? And if not routine, what certain circumstances do you use those for? And the second question is, there's a patient in the room who said that she was told that she's developed ischemic heart disease on the basis of small vessel disease, presumably from endomyocardial fibrosis. And the question is, just in the process of developing cardiac heart disease, in addition to hurting valves, do you actually compromise the coronary circulation in any way, which is not something that's normally reported?
Okay, so I think you asked 4 questions, so I'll see if I can go over that. So question number 1 was, what's the use of cardiac MRI and transesophageal echocardiogram? So I'm head of echocardiography in London, and I'm the guy who does TEEs. TEEs are basically almost no role unless you're looking for something very, very specific in the heart. So let's say there's an abnormality in the aortic valve in somebody who has carcinoid heart disease involving the right side of the heart. And the surgeon wants to know, and should want to know before he goes in, what is going on with that aortic valve. Then a TE would be indicated. Cardiac MRI is a very good test just before surgery to look at the right ventricular size and function. It really, in my mind, in place, does not have any other role in carcinoid heart disease. I can basically tell my surgeon, I only have one surgeon I deal with, because I want, for my patients, I want to have one surgeon and a group of anesthetists who know how to get my patient through the OR in the postoperative period. So I only deal with one surgeon. I'm confident all the information that I need to give to my surgeon I can get from a transthoracic echo. So that's part number 1, or part 1 and 2. The other questions I have completely forgotten because I'm a cardiologist. Can you remind me?
The question was whether the fibrotic process that happens in the heart could compromise small vessels, coronary artery vessels.
Yeah. So a couple quick questions, or quick points about that. So at least I thought initially that these fibrotic plaques develop over years. They actually can develop very, very quickly. We can have somebody who has a normal echo at let's say, January 1st, and June 30th, they'll have a grossly abnormal echo. So actually these plaques are developing a lot quicker than we think. So I forgot to mention that in my talk. Number 2, can this process cause small vessel disease? Probably not. We don't think it does, but we don't know because we don't do left heart caths on these people on a routine basis. Are they prone to getting ischemic heart disease from the therapy? No. But if there are large fluctuations in blood pressure with hypertension occurring for whatever reason, yes, they will have a higher incidence of getting ischemic heart disease, and we are very aggressive in treating ischemic heart disease, and there are no contraindications in treating these people for ischemic heart disease.
Thank you.
Just a quick comment on that second cardiology paper from Mayo. That 1989 was fortuitous, but that's January of 89 is when octreotide was FDA approved in the United States, and the number of patients that they reported in each group started to drop by the group C. So they had fewer patients in that group C by the time they looked at that third group, if I remember right. And the last thing is, what is that level of 5-HIA that's concerning? They went from 350 down to 250 per 24 hours, and I must say I haven't seen a whole lot of 250s even in the last 10 years. So I think what number you use when you say 5-HIA What number do you start to worry?
Well, I'm a cardiologist, and so I actually tell my oncologist, you have a problem here, your levels are way too high, and basically I want the levels down as low as possible. And basically, to make sure that my point gets across, I tell the patient and his or her significant other, this is what you need to go back and tell your oncologist. I'm saying that a little bit with bated breath because the oncologist at LHSC is sitting over there and is actually looking like he's going to shoot me. The other thing that is very important, at least from the cardiology literature, is that the tumor burden in the liver is extremely important. So I do not now like my patients to have their valves replaced unless, A, the levels of 5-HIA are low, but also if there's a heavy tumor burden, that they've had hepatic resection. There's pretty good evidence, in fact, very good evidence showing that if you get your tumor burden taken care of with hepatic resection, you're going to do very, very well from a cardiac point of view after having valve surgery.
Just one small little comment is in the survey that we did of 400 patients with carcinoid, about 50% of them develop hypertension. So I would like to add one more line to why the left ventricle can become burdened in people with carcinoid tumors, and that is because of uncontrolled hypertension. And people tend to forget that, okay?
Thank you very much for your time and your patience.